Okay, I'm going to talk about some advances in ADHD, and I think, at least from my point of view, one of the big advances is we no longer think of ADHD as only a childhood condition. We think of it as a neurodevelopmental disorder with implications across the lifespan. So what is ADHD? It's a common neurodevelopmental disorder. It's associated with significant adult psychopathology. The symptoms are present in childhood, but they often persist through into adulthood, resulting in significant impairment. One of the issues that is raised repeatedly is the common occurrence of comorbidity, but it is worth pointing out that all psychiatric disorders show common comorbidities, and I'm not sure that ADHD is any exception, is any different from other psychiatric conditions with that regard. It is often confused for other disorders, but I think in large part that is also due to the inexperience that many people have in understanding the diagnosis and treatment. And in fact, when we've put together consensus guidelines with various groups of people, we find that among the experts in the field there's a great agreement and consensus about what the diagnosis is and how to make it. And so at least my view is it's no more difficult to make the diagnosis than other psychiatric conditions. There's a lot of data on validity. It has been raised in the past. I'm not going to discuss that today. And I think one of the nice things about ADHD is we do have good and effective treatments. And so I think one of the advances is really just bringing that understanding so that more people can understand sort of when and how to use the available treatments for ADHD. The guidelines, there are a few different published guidelines, and they're all worth reading. The European Consensus Statement is a nice summary. The BAP had the original publication from David Nutt and has recently updated that, published last year. And of course the NICE guidelines is quite an extensive and detailed document, and there's going to be a revision of that in the coming year as well. We know that the effects of stimulants on ADHD are not just short-lived, and there's been a number of studies like this one where the blinded controlled part of the study went on for 6 months. And so you can see you get quite stable drug versus placebo differences over extended periods of time. So some key principles, I've already mentioned some of them. I think we ought to view ADHD as no more difficult to diagnose than other common mental health disorders. So all of psychiatry can be difficult, but ADHD is no more difficult than others. It is a very symptomatic disorder, and I think one of the confusing things is it's often described in behavioural terms, but when you actually speak to patients, they do describe many symptoms, such as their mind being on the go all the time, feeling very restless, not being able to get to sleep at night, and having sort of low self-esteem, for example. So these kind of symptoms, when they're put together, can of course look like other mental health problems. We know that it's often misdiagnosed, and so one of the sort of main aims is to help people better understand how to recognise and diagnose it. And as I said, it is in most cases treatable. One of the best ways to make the diagnosis is to use the DIVA interview. This was developed by Sandra Coy. It was really written for Europeans, but it's been translated into many different countries. And I know that the groups here who are doing research in this area in Turkey are using this DIVA interview. It takes you in a very systematic way through all the criteria, and I would really recommend that this is the gold standard that is used. It essentially takes you through all the symptoms of ADHD for childhood and for adulthood. It does take about 40 or 60 minutes, but I think if you want to make the diagnosis correctly, this is what you have to do. And it's essentially an interview with the patient, but it is very useful to have an informant, either a partner or parents, to tell you about what people are like and also what they were like from childhood. One of the difficulties with ADHD is, like some other conditions in psychiatry, it is essentially the extreme and impairing tail of a normally distributed trait. And so it does mean that it becomes somewhat arbitrary where you draw the diagnostic criteria. You know, how severe do you have to be given the diagnosis of ADHD? But the principle is that you have high levels of symptoms causing impairment, and it's when people are being impaired by these symptoms that you feel you should be treating it. And the impairments are in many different domains, and I tend to split them up into what I think of as psychosocial or functional problems in education, social relationships, coping with daily activities, having accidents, and behavioural problems. But then there are also more psychiatric or mental health types of complaints, being distressed by experiencing the symptoms of ADHD, having low self-esteem linked to the problems, having emotional lability. I gave an extensive talk on that earlier at this meeting, and having sleep problems. And of course, people with ADHD in childhood are put at risk, greater risk for developing other disorders later in life. So they are more likely to develop anxiety, depression, addiction, and personality disorders, for example. And the other aspect which I'll come back to in terms of treatment is you do see a lot of cognitive impairment. And so these are often measured in terms of reaction time or inattentive ability, inhibitory response, reward impairments. But also there are other specific problems people often co-present with, such as dyslexia and reading difficulties and other general and learning specific problems. The executive function model has been very prominent, particularly in the United States. And at least at a descriptive level, in terms of behaviour, I think it works very well. And Tom Brown describes what he feels are the 6 main facets of executive function in ADHD. Problems in organising, prioritising and initiating work, your ability to focus and to sustain your focus, difficulty in regulating your alertness and sustaining your effort, also emotional problems, emotional instability, problems utilising working memory, and monitoring and self-regulating of activities. One of the great problems has been when people have tried to link these sorts of descriptions of executive functions to actual cognitive and functional tests, brain-based tests of executive function. They haven't found very strong links between one and the other. So there still is quite a big open question, I believe, about what is really causing these problems in ADHD. Now, the treatment will tell us a little bit more about that. And of course, there's been quite a lot of fMRI studies now, both in children and adults. And so really just a very brief summary of some of the key findings. That repeatedly people have found reduced activation in inhibitory networks and also in reduced activation in attentional networks. And so there has been a strong assumption that these then underlie the symptoms of ADHD, and probably the treatments sort of act on these systems. We know that the main effective treatments work predominantly by either enhancing dopamine or noradrenaline. So atomoxetine works specifically on noradrenaline, particularly in the prefrontal areas of the brain. On the other hand, that actually, in that part of the brain, there is no dopamine transporter, and dopamine is also increased as well as noradrenaline by atomoxetine. But that's where most of the focus has been. It may well be that the other neurotransmitters are involved, but I think that is the main story at this point in time. It's also been shown repeatedly that there are problems within the reward pathways in the brain. And in terms of reward anticipation, you can see in this meta-analysis that all studies, in fact, apart from our study, but every other study showed that there was reduced ventral striatal responsiveness to reward. And that might be why people with ADHD are very reward-seeking. They function best in highly rewarding environments. They do rather poorly when in a kind of low-stimulus environments, and this may be linked to this deficit. So the medications, I'm not going to talk about the medication effects on the brain, but in terms of, although there are many and they are well described, but in terms of cognitive performance, you can see in this meta-analysis from David Coghill that there are reasonable effect sizes, particularly on aspects of memory, non-executive aspects of memory, reaction time, but actually more critically reaction time variability. And that has already been shown in ADHD, that it's the variability and the regulation of reaction time rather than the mean slowing of reaction time, which is more specific to ADHD. And also response inhibition. So the treatment affects all of these different processes. But when people have then tried to say, well, do improvements in these functions lead to improvements in ADHD symptoms, the answer has actually been no. They seem to be drug effects on these cognitive functions, drug effects on ADHD symptoms, but you can't show, or it hasn't been shown, that change in one is leading to change in the other. So these may in fact just be different facets or aspects of the brain disorder we think of as ADHD, rather than one leading on to the other in a kind of neat causal way. But some of the better work in this area has used neuroimaging, and Newcorn and Schultz in New York in particular have been looking at treatment effects on the brain and correlating those to treatment effects in terms of ADHD symptoms. And they were able to show that for both methylphenidate and atomoxetine, that improvements, particularly in this region of the motor cortex, correlated, that changes in this region in terms of activation correlated with improvements in ADHD symptoms. They also found in some other regions of the brain that atomoxetine seemed to work in one direction and methylphenidate worked in another. So that was interesting to think why that might be. And these were areas of the right inferior frontal gyrus, the anterior cingulate cortex, as well as supplementary motor area in the posterior cingulate cortex. So these regions seem to have more direct evidence for the drug effects sort of leading on to clinical improvement. The drug effects themselves are quite well established. So you can see there's been a large number of studies of methylphenidate in adults with ADHD. And these give an average effect size of about 0.48. And there's not much to say about that. I think with time, the effect sizes have come down. And curiously, that's probably because placebo rates have gone up. And I think that is a general phenomena across psychiatry. So I don't quite know why that is. It may be we're broadening our concept in including milder patients, where you get a bigger placebo effect. If you take more severe patients as your starting point, you tend to get bigger effect sizes. The other thing we know from these studies is that there is to some extent a dose-response relationship. So to get the biggest effect sizes, you need to titrate up for each individual to an optimal dose level. And that's really what we see in clinical practice. We have to fine-tune and titrate very carefully for each individual patient. There is no simple milligram per kilogram formula for the use of stimulants in ADHD. So the approach is to begin with a low dose, titrate up in a regular fashion to optimize the treatment effect while minimizing adverse effects. And you get a wide range of final doses in different people. Amphetamines have also been widely used. They're not so much used in the UK. I think it's correct that that has been because of fears of drug abuse, although there isn't strong evidence that it is abused any more or less than methylphenidate. But there is also now a very interesting new medication called lisdexamfetamine, which is a prodrug of dexamphetamine. And this essentially is a protein. The dexamphetamine is bound up with a protein and is inactive until it's released. And that release only happens once it's gone into the bloodstream. It goes onto red blood cells and an enzyme sort of cleaves off and releases dexamphetamine. And so actually, whether you take it orally or inject it or snort it, you have the same slow sort of entry of the drug into the brain. And so actually it has a very low abuse potential for that reason. If I have time, I'll come back to that later. The other thing to say here is that the effect sizes for amphetamine seem to be slightly higher than for methylphenidate. And that has also been shown in children. So it's a little bit controversial, but at least that would be my judgment, that the effect sizes, as shown in these studies, the average effect sizes do come out as slightly bigger for amphetamines than methylphenidate. Atomoxetine, the effect sizes have actually been very consistent across all the different studies, and they average out at about 0.4. So not that different from methylphenidate, but a little bit less. Somebody asked in a previous talk about modafinil, and wasn't modafinil a good treatment for ADHD? Well, it's not been licensed, even in the US, where many drugs are licensed for ADHD. And I think you can see in this study, I guess you could say it's not a large study, so it's probably not in itself definitive, but it had 338 individuals. It compared modafinil with placebo at different doses, but you can really see there's no difference here between the drug arms and the placebo arm. So I think based predominantly on this study, there's not much evidence for modafinil. So it is interesting, even if it may be a dopamine drug, it's not acting quite in the same way as methylphenidate or dexamphetamine. Why would you choose stimulants or atomoxetine? They're quite different. Stimulants, it's the immediate effect of the medication itself. So when you take the medication, the effects come on quite quickly. For immediate release stimulants, the effect lasts 3 or 4 hours and then it wears off. For the longer-acting medications like Concerta or lisdexamfetamine, it may last 8 hours or 10 hours. Atomoxetine is a drug much more like an antidepressant. It's a specific noradrenergic reuptake inhibitor. The effects build up slowly over a number of weeks. And it's thought that the full effect doesn't really emerge until somewhere between about 6 weeks and 12 weeks. So you actually have to be quite patient in taking it religiously every day at the right dose, and then the effect will slowly build up over time. So you can see they're rather different to use. One, in a sense, is easy to use, atomoxetine. Stimulants require a little bit more skill from the clinician and the patient to titrate to the right dose. But people rather like using stimulants because, of course, you do get a very rapid feedback from the patient that, yes, this is a drug that's affecting my symptoms. You can measure that very rapidly. With atomoxetine, it all takes a little bit longer. Atomoxetine might have advantages in very unstable patients if you need a 24-hour effect. Because effectively with stimulants, although you may be treated during the day, by the evening the medication will have worn off, and through the night you'll be unmedicated. When you wake up in the morning, you are essentially unmedicated. And one of the reasons why stimulants don't seem to generate tolerance over time or addiction when used in a therapeutic way is because by the morning the system has reset itself. And there isn't good evidence that there is tolerance developing in patients who often remain on exactly the same dose for very long periods of time. The other thing I wanted to say about addiction with these drugs is one of the big problems we have is keeping children who were on it during childhood, but as soon as they hit adolescence, they choose not to take medications and they just stop. So there really is no evidence that, the big problem in adolescence is even with impaired adolescents with ADHD is actually trying to persuade them that they ought to think about continuing with a drug that's been very helpful to them. So there really is no evidence of drug-seeking behaviour in that age group, even if they've been on these drugs for a long time. You can see the different profiles of the different drugs. And if you take short-acting medication, you often need to take it 2, 3, or even 4 times a day. Drugs like Concerta sort of have this extended action over a longer period of time. And sort of drugs like Equisim and Medikinet, the effects last about 6 hours. So the nice thing is you can sort of titrate to each individual to get the right effect for the right amount of time. And as you become more familiar with these drugs, it's really quite nice that you can work with the patient to sort of fine-tune it to the right dose for different people. The standard dose we use for methylphenidate, I always think about what would you use if you were going for the short-acting. And the average dose in an adult would be 10 milligrams 3 times a day. And then a higher dose might be going up to 20 milligrams 3 times a day. And just rarely you might use doses like 30 milligrams 3 times a day. So that's the kind of average. Some people need more, some people need less, but probably the majority would fall within that sort of bracket. And the other drugs just sort of map onto that. Concerta comes in 18 milligram sort of units, and each 18 milligrams is equivalent to 5 milligrams 3 times a day of the short-acting medication. So you can kind of translate from one to the other. Equisim and Medikinet have a sort of a different ratio. Medikinet, you get 50% immediate release, 50% slow release. Equisim, you get 30% immediate and 70% slow release. I'm going to pass over these slides because I'd like to get on to the next section. Can I just check how much time I have?
We are already out of time. Out of time.
Sorry?
It's over.
Over, okay. Then I just really want to say something quickly about substance abuse. With these medications, we take them orally. And when you take stimulants orally, you get a very slow sort of entry here. And this doesn't seem to cause any kind of high and has a very limited abuse potential. When you inject these drugs, they go into the brain quickly, and that's what gives you the high. This was shown by Nora Volkow, that compared sort of injecting methylphenidate, and you can see that the more you take, the more you experience this feeling of being high. But if you do the same when you take it orally, you can see there's no relationship between the dose you take and feeling high. So the trick is to use medication that you can't use in other ways. You can't inject and you can't snort. And so certain of the products are good for that, and others are less good for that. The other thing to say is that a meta-analysis has shown that when you treat people with addiction problems, with drug dependency, with stimulants and other medications, you can see there's a meta-analysis across different groups of drugs, you do get an effect on ADHD, but unfortunately that same analysis shows you get no effect on abstinence or the drug dependency behaviour. So I think at least it's an area where we can see, yes, there may be some benefits to the patient in terms of symptoms and function, but it doesn't seem to get a core problem that people with a serious dependency problem have. And so we may need to think a bit more about how do we, treating ADHD doesn't seem to be such a great answer for treating drug addiction as we might have thought. So I'll end up with this slide. It's just a simple treatment algorithm. You need to recognize the disorder and diagnose it. You need to take into consideration risk of substance abuse. But the biggest problem has been diversion into education by students. That's the big problem in the US. It actually isn't people abusing it to get high. And so I think that is something to bear in mind, that there is a diversion for cognitive enhancement, but not really abuse in terms of drug abuse in that sense. So you do need to take that into consideration. If you're not worried about those things, of course you can go down and treat. People recommend methylphenidate first. Second line could either be atomoxetine or dexamphetamine. And then you've got third line drugs such as bupropion or guanfacine or some of these antidepressants like venlafaxine. If there is substance abuse, we would generally, if you're worried about that, we would generally recommend atomoxetine first. Then perhaps bupropion. We wouldn't rule out stimulants, but it's something you would need to think carefully about. So I'll end on that point. Thank you very much.
Thank you.